And I've been given quite a broad title, and I've taken the liberty to divert a little bit from the brief, but I hope it's all pretty much in line with what was expected. Thank you very much for the opportunity to present. I think we all know these figures, so there's no need to dwell on them, but the figure I would like to keep in mind for this presentation is the 1 million HIV-related deaths and the fact that 400,000 of those are TB-related. When we talk, one of the, I think 1990 has been a fantastic target to catalyze action and while trying to improve quality, but one of the shortfalls of 1990 is it doesn't talk about mortality, and in a lot of national program reviews we've been involved in, it comes out that people show good HIV cascades, they give us 1990 data, but mortality is somehow lost from the picture. And of course, adherence and retention is very much related to how we do a better job of getting successful outcomes on antiretroviral therapy. So this, again, we all know, or at least the cascade on the left will probably be very familiar to you, the dropouts in between, well, from not knowing your status to being diagnosed, and then to starting antiretroviral therapy, and then to staying on antiretroviral therapy for what could happily now be 20, 30, 40 years of disease-free life, and having that successful outcome. We have gaps along the cascade. The graph on the right is from the IDEA cohort collaboration. It's a combination of data from around 50 countries worldwide, and it shows a pretty stark picture of retention in care. By about 5 years, on average, 40 to 50% of people will have dropped out of care. Some of those may have re-engaged in care and been counted twice because we don't have good unique identifiers in programs, particularly in Africa, but nevertheless a pretty worrying picture about the retention in care over the long term. Men do worse than women, adolescents do worse than the average general population, and children fare pretty poorly too. So progress in the cascade of care, very uneven. Here's Africa. It's not doing as well as other parts of the world, but it's doing a lot better than some highly, much better resourced parts of the world in terms of the number knowing their status, the number getting on treatment, and the number staying on treatment. So if you compare to other WHO regions, one can say that Africa is somewhat in the middle of the global or the regional picture of cascades of care. And finally, we have more recently had our attention drawn to us through the various data sets of an enduring challenge of advanced HIV disease. This is one graph from South Africa using NHLS data, so anyone who got a CD4, and asking the question, what was the CD4 at start of treatment in 2016? And the data is quite frightening. It shows that still a third of people are starting treatment with a CD4 below 200, what some researchers previously used to call the death zone because of the much higher risk of severe opportunistic infections and mortality. And 17% started with a CD4 at below 100. And this is in the era of treat all. This is in 2016. And men were twice as likely to start care with a low CD4 count compared to women. So I'm going to address 3 topics in this presentation: ART initiation, adherence and retention, and then talk briefly about advanced HIV disease. And I'm going to also, at the end of each section, summarize some of the key research questions for WHO. I'm delighted to be presenting to a room full of researchers on the continent with the greatest burden of disease. And when WHO makes guidelines, they do quite extensive systematic reviews of the literature, which not only tell us what to recommend, they also tell us what the gaps in research are, and we bring together quite a diverse group of experts worldwide to interrogate that data. So hopefully the research gaps that we highlight through our guideline processes are pretty solid ideas of important questions that need answering. So ART initiation. We know that treat all has been very rapidly taken up around the world. As you can see, just 2 years ago, when the guidelines first came out, most of the world was not implementing treat all, and certainly virtually no country in Africa. And in barely 2 years, the majority of countries worldwide have taken up this policy. And this is some early data, and we're all convinced by the randomized trials that show reductions in mortality, morbidity, and risk of onward transmission. But we don't have a huge experience of treat-all in real life, and this is early data, again, from the IDEA cohort collaboration, showing that treat-all increases the number of people who will have started ART within 3 months compared to other initiation criteria. And I'll go on to show a bit more data as to why that's important. One of the linked recommendations after the treat-all recommendation was the question of how if you can start ART as soon as an HIV positive diagnosis is confirmed, if you don't need a CD4 count or WHO staging, well then how quickly should you start ART? And in 2016, when we were doing our guidelines, we didn't have enough evidence to make a recommendation. But in just a year and a half, 4 randomized trials have reported and a number of observational studies have reported, and they all point in the same direction in showing that starting ART rapidly, so within 7 days of a confirmed diagnosis, and sometimes starting on the same day as an HIV confirmed diagnosis, leads to lower loss to follow-up at 3 months, at 6 months, at 12 months, a better chance of viral suppression at 6 months and 12 months, and reduced mortality. So starting quickly is beneficial compared to delaying treatment for prolonged adherence counselling and perhaps clinical workup. And this recent study, which was reported at CROI and published that same week in March this year, looked at the issue of starting on the same day, but in the community setting, so community-based testing plus ART initiation compared to referring people to the clinic and starting ART at the clinic level. And it showed that there was a durable benefit across a range of parameters to starting ART outside in the community. This is not yet a recommendation for WHO, but we're very interested in these and other data, and I think the next time we sit down to do service delivery guidance, we will probably make a recommendation to go to this next step of task shifting. So the research questions that came out of the last couple of years of treat-all, accelerated ART initiation and related recommendations were we need more data on the benefits and challenges of implementing treat-all, particularly key populations, adolescents and pregnant women in operational settings. We need tools to assess client readiness for same-day start, so there are contraindications to starting ART quickly, and we need simple validated tools to allow rapid decision-making, probably by lesser trained health professionals at primary care level. We need to know the long-term outcomes of rapid ART initiation. We've only got about a year's experience of that. And we need to continue to follow this emerging evidence on outcomes of starting ART not in the clinic, but at the community level and referral to clinic thereafter. So on to adherence and retention. This is a review of barriers to adherence, a bunch of studies that ask patients why they're not adhering to medication. And as you can see from this cumulative estimate of the different reasons why people are non-adherent, the answer is there's a large range of reasons why people are non-adherent. And for those of you who until recently had great confidence that dolutegravir over efavirenz was going to solve all of our adherence and retention problems, well, you just have to look at studies like this to understand that drug toxicity, while it may have been a pretty important problem 15 years ago, it's not the main reason why people are suboptimally adherent to medication. We need to provide the best medicines we can, but we need to solve quite a large range of barriers to optimal adherence. And in the same systematic review, the main reasons for suboptimal adherence were mapped against the evidence-based interventions that we know and that for the most part are recommended by WHO. So I think this is a very important approach, and the main message to this approach is to say there is no one magic bullet to solve adherence problems, and we need good evidence-based interventions, but we need a package of those interventions because adherence problems are various and they change over time. I wanted to draw your attention to this interesting study that was recently done, again from IDEA, but here in Rwanda, that was looking at predictors of more rapid ART start and protection against loss to follow-up. And what came out of this study was that 4 counselling sessions, not necessarily all done prior to starting treatment, led to much better outcomes, and in multivariate analysis in loss to follow-up was the best predictor of remaining in care compared to fewer counselling sessions. And it highlights the fact we all know adherence counselling is important, but there is no guidance about what is the best frequency and duration of adherence counselling. So we need, in my view, a much better understanding of that to really make counselling work. Differentiated service delivery, you've all been hearing about it for years, but there's good emerging evidence showing from a range of different settings, including high-income settings as well as in Africa, that it improves retention, it improves other health-related outcomes across a range of settings. So the more the evidence accumulates, the more it supports this approach to less frequent clinic visits, less frequent drug dispensing for those patients who are ascertained to be doing well and understanding the messages around ART. We have the next presenter covering viral load, but of course a key bit of the adherence issue is how do you measure adherence? How do you know when someone's not doing well? And still today the gold standard is viral load. The good news is viral load access is increasing. The bad news is acting on the results we get from viral load is highly variable, and this is data from a study from MSF a couple of years ago. There's other data that shows the same thing, which is that when you get a viral load, not everyone does the adherence counselling that should follow from a single first high viral load. If they do, they don't necessarily do a second viral load, and if they do all of these things and have confirmed failure, not everyone is then switched to second line. So again, technology is important, but thinking in a magic bullet approach is not going to get us where we need to be. So the research questions on adherence and retention for us are continuing to question the optimal frequency of clinic visits and drug dispensing. WHO currently recommends 3 or 6 months. Is 3 months better? Is 6 months better? Could we even go longer? The optimal approach to adherence counselling, I showed the Rwanda data. There's not much of that kind of data about. We need more. Interventions to improve the viral load cascade, as we may hear in the subsequent presentation, and differential adherence and retention that has always been a hypothetical concern in the era of treat all. We need to look at that closely in the rollout. So finally, on advanced HIV disease, I showed you the slide on the left, which shows that among people starting treatment, there's still a substantial proportion of people who start treatment with a low or very low CD4 count. And this data on the right from the Western Cape in South Africa shows that advanced HIV disease is not just a question of late presentation, it's increasingly a question of people who disengage from care and after a certain period of time off ART represent for care at a very late stage of advanced disease. So it's not a one point in time concern, it's a concern throughout the duration of ART therapy for those people who interrupt treatment for a diversity of reasons. What we do know, thanks to the recent renewed attention around advanced HIV disease, is the main causes of morbidity and mortality among people with advanced HIV disease are clustered, and they're the ones you would probably guess. It's TB, it's cryptococcal meningitis, it's severe bacterial infections, and it's roughly the same for adults and children, with some differences like cryptococcal meningitis not being as important for children. And knowing that there are common causes to mortality and morbidity in people with advanced HIV disease allows for a public health approach. And this is what WHO worked on in the last 12 months. We put out guidance around this time last year, and we recommended a simplified package of diagnosis, prophylaxis, ART initiation and counselling that all individuals presenting or representing for care with a CD4 below 200 should get, because this simplified package of care has been shown in a number of clinical trials with certain adaptations to lead to a significant reduction in mortality among people with advanced HIV disease. I just wanted to put a plug into one of the components of the packaged intervention, which is a fixed dose combination of INH, cotrimoxazole and B6. As many of you may know, uptake of cotrimoxazole has been pretty good in most parts of the world, including Africa, but uptake of INH is usually dragging behind. We recommend both for advanced HIV disease, and we have a generic fixed dose combination of these different medications. It's scored, so you can split it and give it to children, and in the coming weeks an announcement will be made about a preferential price for this important innovation. Relatedly, we put out guidance on cryptococcal disease. There's still a lot of work going into trying to improve diagnosis and treatment for severe opportunistic infections. This guidance came out in March. And we have a bunch of research questions that came out of all of this work. The feasibility and impact of implementing the advanced disease package. We know it works in trials. How well does it work in real life? Semi-quantitative CD4 cell count. There's been a reduction in the investment in CD4 around treat all because there's been an understanding that if you don't need CD4 to start treatment, and you don't need CD4 to measure treatment effectiveness, then perhaps we don't need CD4 at all. And the recent advanced disease work, I hope, has highlighted that that's not correct, that the best way of assessing disease risk and progression to death is CD4 cell count. But we need new tools that work well at primary care level. Can we use these associated diagnostics, so LAM for TB, cryptococcal antigen test at a single threshold? They're currently recommended for a lower threshold of 100. Do they work at 200? We need more research to look into that. Additional prophylaxis for severe bacterial infections. The reality randomized trial used azithromycin. Is it the best choice? Are there other interventions for severe bacterial infections? We need to think more. Managing advanced disease in those people who disengage from care and come back. Is it the same approach? Does it need to be modified? And continued improvements in the management of cryptococcal meningitis. In the coming period, we'll hopefully get trial results telling us whether a single high dose of liposomal amphotericin B works as well or better than the current 1 to 2 week treatment we propose to these patients. So in summary, treat all has been one of the most rapidly adopted global policies in the history of WHO guidelines since 2002. Within 2 years, almost every country in the world has taken this up. But there are several emerging and re-emerging, in the case of advanced disease, challenges around adherence, retention, and management of the severely sick, and a number of opportunities that present themselves. So we were not thinking about same-day start 6 years ago, but treat all allows us to think about that and to look at the benefits for programs. Can we start ART safely outside of the health setting? We've got randomized trials that suggest we can, but there are probably risks associated with it. And looking further at nuancing further optimizing differentiated service delivery. And for you all, there are a large range of outstanding questions for WHO and beyond, and clinical and implementation science research are absolutely critical to helping us with further improvements to improving HIV treatment outcomes and reducing adherence and retention. Thank you very much for your attention.